All right, so here we go. So integrated relapse prevention planning for co-occurring disorders. So substance use and mental health disorders are generally chronic, persistent, relapsing illnesses. That means that they are hard to treat, they last for a long time, and even when they are treated, both substance use disorders and mental health conditions have an unfortunate tendency to come back. So in medical care, which both substance use and mental health treatment belong, a relapse is a formal phrase that indicates a recurrence of a past condition. So both substance use and mental health disorders have a heightened risk of relapse because of the chronic nature of those disorders. So in a substance use relapse, what we're seeing is a return to using substances in a harmful or problematic manner. Note that I didn't say that a relapse is a return to using substances, period. In many cases, that is true, especially when abstinence is the overall goal. But as we've already been introduced to harm reduction in the co-occurring class, as well as some of the other classes, that's where the field has evolved, is to consider a relapse being a return to substances in a harmful or a problematic manner. So we're going to use that as our guideline for today's lesson. And a mental health disorder relapse is a return to problematic symptoms and or the intensification of regular symptoms. Meaning that maybe somebody has bipolar disorder and they tend to have bipolar symptoms, but they're manageable. They're not problematic, but then they go through a period of their life where the symptoms become unmanageable or intense in some way. Person is depressed, but they are managing their depression, and then they go through a period of time where suddenly they are thinking of hurting themselves or ending their life again. So that would be a relapse to problematic mental health symptoms. So the overall goal of treatment for co-occurring disorders, like for substance use disorders and mental health disorders, is essentially relapse prevention planning. How can we help prevent a return to problematic symptoms and behavior? However, relapse is very common for clients with co-occurring disorders, both during and after treatment, meaning that many clients will relapse while they're in treatment for co-occurring disorders, and many will also relapse shortly after leaving treatment for co-occurring disorders. Now, this is a very important philosophical stance. Relapse does not necessarily mean that the client has chosen to defy substance use and mental health treatment goals and return to the problematic state they were in prior to engaging in treatment. So it doesn't mean that when somebody relapses, they've said, oh, screw it, I'm not doing any of this stuff, I'm just going back to life the way that it was. And relapse does not necessarily indicate that treatment has failed. So I want you to note that the major clinical governing bodies, the agencies and entities that dictate the work essentially that we do as drug and alcohol counselors, which includes both SAMHSA and ASAM, explicitly state that relapse should not be considered a failure in treatment. Rather, a relapse is an opportunity for additional learning to explore ways of improving treatment to decrease relapse frequency and duration. So with co-occurring disorders in particular, people relapse all the time. They go back to the mental health symptoms that are causing problems, and they go back to using substances in some capacity. And so if we approach that as a failure of treatment, then treatment essentially ends. And what SAMHSA and ASAM and numerous other organizations have said is that relapse is a part of the process. So instead of ending treatment as soon as somebody has relapsed, what you want to do instead is evaluate, well, what happened there? How did the person go back to using substances or having symptoms that are problematic? And can we use that relapse as learning to update the relapse prevention plan so it doesn't happen again? So a relapse prevention plan can be used both preventatively prior to the relapse, and it can be used in response to a lapse. Now, lapse is one of those words, for those of you that have taken the family class before, you know it often creates great big debate about what's a lapse. Well, is using once a lapse? What about twice? So essentially a lapse is either a single episode or a brief return to problematic use or symptoms, and then the person gets back on track. So in the case of a substance use disorder, if somebody used once and immediately called their sponsor and went to 90 meetings in 90 days and recommitted to abstinence, that would be considered a lapse. But if they used once and they used the next day and then they immediately called their sponsor and did the same thing. The fact that it was 2 use instances instead of 1 doesn't mean that it's not a lapse anymore. So it's kind of a fluid definition, but the idea here is that a lapse is simply, oh, I've fallen off the horse, I get back on, and I recontinue with whatever my goal is. So the idea is that you can use a relapse prevention plan to deal with a lapse or a relapse to avoid escalation to a full-blown relapse and more serious consequences. So relapse prevention is considered a prerequisite for any attempt to treat and facilitate long-term changes in both substance use and mental health symptom management, meaning you can't do treatment without including relapse prevention. It is a requirement. Most people who don't receive relapse prevention will relapse. It amazes me, actually. There are still a handful of agencies out there that don't have any relapse prevention. They don't have any relapse prevention groups. They don't have any relapse prevention plans. It seems kind of crazy to me, seeing as how Center for Substance Use Treatment, which is SAMHSA, ASAM, all those folks have said that relapse prevention is the entire purpose for why we exist. So, side note, I want to skip over and talk about something that's really relevant to the work we do in substance use treatment facilities. So in 2018, so 2 years ago, the California laws for substance use treatment facilities changed. And the change in the law, or the amendment, is listed here on this slide. So the law now states that any substance use treatment program that is certified or licensed in California shall develop a plan to address when a resident, which is a person receiving services, whether or not it's a residential facility, when a person relapses. So an agency has to develop a plan to address when a person relapses, including if they're on the premises after consuming alcohol or illicit drugs. And then the highlighted section here is the plan shall include details of how the treatment stay and the treatment plan of the resident will be adjusted to address the relapse episode, how the person will be supervised, etc. And the last sentence down there says this subdivision does not require a licensee to discharge a resident. So for many, many, many years in substance use treatment, if you relapsed, you were gone. And that was it. There was no clinical intervention. You showed up dirty on a test. You had 24 hours to leave the program. If it was a residential program, if it was an outpatient or an IOP program, you probably had a meeting with a counselor or program manager, and they said, see you later. Come back when you're ready to get sober. So in this case, California has changed the law to state that the treatment plan needs to address the relapse episode itself, and you are not required to discharge the resident. So in other words, you have to have a plan for how you're going to address when clients relapse, and this shall be a clinical intervention. So again, the quote, the plan shall include details of how the treatment stay and treatment plan will be adjusted to address the relapse episode. So how the treatment stay and treatment plan will be adjusted to address the relapse episode. So note that the legal text specifically uses the phrase continued care planning. So that indication is that the state expects the client is still in your clinical care following relapse. So this emphasis on adjusting the treatment plan and the overt statement does not require a discharge strongly suggests that the state wants programs to address relapse while keeping clients in the program. Now, in spite of what you may have heard about California being a nanny state, the state has not stated that you must keep them in your program. They are instead suggesting it does not require a discharge, which is essentially state lingo for please don't kick this person out of the program and adjust your treatment plan to address the relapse. So, in other words, the law now recognizes that relapse happens. It's common, and it should be considered an aspect of the substance use treatment. So by state law, it's the agency's responsibility to develop a policy and a plan for how the agency is going to address relapse and, whenever possible, continue the treatment. Now, especially in the case of co-occurring disorders, the law also makes it an agency responsibility to develop a procedure to determine that a resident requires services beyond the scope of the program. So if you're in an outpatient treatment program and a client, continues to relapse, as long as you've got a plan that states that based upon this relapse, we are going to try and get this client to attend a detox program or something like that, that falls within the scope of the law. But essentially, as best as they could say, the state has said stop discharging people and ending treatment when they relapse, and instead figure out how you're going to accommodate that. Okay, so let's get back to our regularly scheduled program already in progress. So back to integrated relapse prevention planning. So relapse, both substance use and mental health, is conceptualized as a transitional process, meaning that there is a prior series of triggers and events over time that culminate in the relapse. Relapse is not an isolated incident that comes out of nowhere. So we understand this in the case of substance use relapse. Somebody gets out of treatment and they are going to meetings and they're working with their sponsor and they're hanging out with sober friends. And then over time, they stop going to meetings, and then they stop meeting with their sponsor. And then they start going and hanging out with that Friday night crew at the park, who's always drinking beer. And then they find themselves, going through some kind of major life event that leads them to the park on Friday. And when somebody hands them a beer, they take it and they relapse. So the idea here is that the drinking happened long before. The process leading to the drinking happened long before the drink was actually taken. So it's the same thing with mental health. For example, prior to someone experiencing suicidal ideation, there's usually a series of triggers and events that have happened prior to that lead to suicidal ideation. So here then, that process can be anticipated and a plan can be developed to address those triggers to either avoid or interrupt the process. So if somebody is in the process of moving towards relapse, a number of steps have been taken leading towards this. The plan then is, okay, let's anticipate something like that happening, and what can we do to stop it? So the goal then of any relapse prevention plan is to minimize the impact of those high-risk situations that could lead to relapse by both identifying and increasing awareness of those situations before they're experienced, and by creating a plan to address those situations when they come up. So let me go back to the example that I gave you. Person leaves substance use treatment. They are initially going to 90 meetings in 90 days, meeting with their sponsor, meeting with the sober support group. So when you're doing a relapse prevention plan, you want to anticipate, okay, so what might stop this process? What if you stopped going to meetings? What if you stopped meeting with your sponsor? What if you started hanging around with those guys in the park, who are always drinking beer on Friday? So that's developing a plan for before these situations actually happen. What can we do to make sure that doesn't happen? But a relapse prevention plan also creates a plan for, okay, well, what about when situations come up? What if somebody does hand you a beer? Then how are you going to cope with that? How are you going to set a boundary, et cetera? All right. So in treatment of co-occurring disorders, it's considered best practice to develop a relapse prevention plan that addresses both substance use and mental health at the same time. And this is what's probably different than what you've gotten in your other classes. So as drug and alcohol counselors, it is definitely within your scope of practice to address mental health symptoms, which I think we've established firmly in this class. It is also within your scope of practice to address mental health in a relapse prevention plan. And in the case of co-occurring disorders, it is considered extremely important. Having a middle-aged moment here, the word I was looking for isn't coming to me. It's considered to be extremely important to address both substance use and mental health at the same time. So in some cases, it can be considered unethical to address only substance use relapse and ignore mental health relapse, as many times those untreated or unacknowledged mental health conditions could lead to serious consequences. So again, going back to my example of somebody who has suicidal ideation, if you don't account for depression, suicidal ideation in the relapse prevention plan, and that person has a return to those symptoms, in this case, the serious consequences could potentially be taking their own life. Okay, so While it is acceptable to develop two separate relapse prevention plans, meaning one substance use disorder relapse prevention plan, one mental health relapse prevention plan, it's best practice to develop an integrated relapse prevention plan that addresses both conditions in the same relapse prevention plan, as these two conditions often overlap and are codependent. So there are some agencies out there where the drug and alcohol counselor will do a relapse prevention plan for substance use, and then the mental health clinician develops a relapse prevention plan for mental health conditions. Again, SAMHSA says that that's acceptable, but that's not ideal. This is very similar to the parallel and integrated models for treatment. So an integrated model means that you're doing it in the same place and it accounts for the overlap. I also know some agencies have relapse prevention plans where the drug and alcohol counselor works on the substance use part of the relapse prevention plan, and the mental health condition works on the mental health part of the relapse prevention plan, but it's still one document. That's a little closer to an integrated relapse prevention plan, but in general, it's best that you address both in the same plan, and as drug and alcohol counselors, you are definitely equipped to address the mental health piece. So although there are some templates for integrated relapse prevention plans that are available, the most effective integrated relapse prevention plans are customized and based on the preferences, experiences, and cultural background of the individual. What I mean by that is that if you go online, you might be able to find integrated relapse prevention plans forms that you just fill out with the client. Generally, cookie cutter relapse prevention plans have pretty low success rates. So the best practice is to work collaboratively with your client to design a plan that works for them. And that plan may not be as effective for others. So when you're doing this, you are going to address with the client what worked for them in the past. And of course, assess what didn't work for them in the past. And you're only going to include on a relapse prevention plan those things that the client is motivated and willing to do today. So in other words, like, do 90 meetings in 90 days, that's great, pretty standard for substance use relapse prevention plans. But if the client's not motivated, to do 90 meetings, or they hate 12-step meetings, then that's not going to work. So we're not going to give them a cookie cutter, hey, this is what you should do, immediately leaving treatment. Same thing. You should practice deep breathing techniques, for your anxiety or for your PTSD. Well, deep breathing techniques might work for some people, but other people might not be motivated and willing to do that. And so that's why you want to create a custom plan that comes up with something that the client is willing to do, the client's motivated to do. And like a treatment plan, a relapse prevention plan is considered a living, breathing document. And so you can always update it as circumstances, skills, and motivations change. So, to construct or to write the integrated relapse prevention plan, the counselor and client start with an assessment of both substance use and mental health symptoms. So this is true really with all relapse prevention planning. If you were doing just a substance use relapse prevention plan alone, or a mental health relapse prevention plan alone, or even in the medical field, if you were doing a cancer relapse prevention plan alone, you're going to start with an assessment of what led up to this. So in this case, we're going to consider things like, why did or does this client use substances? Why did or does this client have these particular mental health symptoms? What needs to happen in order to prevent this client from experiencing these same kinds of negative consequences from their substance use and mental health symptoms that led them to seek treatment in the first place? So when you're doing your initial assessment, you absolutely need to consider previous relapses. Previous relapses have very important information. In the case of a previous relapse, you are going to have a very good example of what didn't work. You're going to have a good example of triggers, events, things that happened that led to that relapse. You may have examples of warning signs, that other people saw. There might have even been a plan in place. Your client had a plan to, I'll call my sponsor if I start thinking about drinking, and then they didn't call their sponsor and they started drinking. So there's an opportunity to look at that previous relapse prevention plan as part of your assessment to say, hey, what happened there? Why didn't that plan work? So you always want to consider those plans. What were the thoughts and emotions right before the last relapse? What were the people, places, and things that contributed to the last relapse? What were the warning signs that other people, supportive people, may have seen that could have indicated that relapse was imminent? So The goal then is to use this assessment to gather the information needed to develop the integrated relapse prevention plan. And so once that information is gathered, now the construction of the relapse prevention plan can begin. So the structure of all relapse prevention plans have the same basic components, or should have the same basic components. There needs to be an identification of triggers, things that would cause the person to relapse. There needs to be a plan to address those triggers. There also needs to be an assessment and identification of warning signs. So warning signs are things that other people could see that suggest the person might be moving towards relapse. And a relapse prevention plan needs to enlist key stakeholders or a support system who can come to an agreement about what to do when those warning signs appear. So let's look at each of those a little closer. So triggers. So the identification of specific triggers or a stimulus that would cause problematic mental health symptoms or an impulse to use substances. So note that the word here is specific. So you want to drill down as specific as possible. What are the actual triggers that would cause this person to go back? So general triggers are not helpful because a general trigger means you're going to have a general plan. So, you know, if a general trigger would be you start behaving in old ways. Okay, great. So behaving in old ways could be a trigger, but that's not a specific trigger. What is behaving in old ways mean for this person? And if you don't have a specific trigger, then you're not going to be able to develop a specific plan. Smart goal, right? So triggers may be a precursor, meaning you want to identify triggers that maybe in and of themselves wouldn't directly lead to relapse, but they could start along the road to relapse. Or triggers that might immediately lead to relapse, like, you know, you go home and your dad hands you a beer. So note that triggers may implicate both substance use and mental health relapse risk at the same time, meaning that a trigger might cause somebody to have a panic attack and cause them to drink at the same time. So the same trigger could impact both domains. So when you're doing an integrated relapse prevention plan, you want to account for that fact. Then the plan. So creating a plan means that you create a very particular, specific, detailed plan to implement when those identified triggers are experienced. So the plan may be to try and avoid those triggers, or to interrupt those triggers, or to forestall something from happening, or correct a response that could lead back to problematic substance use or mental health symptoms. You know, so if you know that going to visit your mother tends to create a panic attack, then, you know, one plan could be, well, don't go see your mother. But maybe that would be avoiding. But maybe that's not realistic. So then it might be, okay, so what if you are visiting with your mother and you start to have a panic attack? Then what would be the plan that you can do to interrupt that panic attack? So if I start feeling like I'm having a panic attack, I'm going to excuse myself, go to the bathroom, and I'm going to practice deep breathing. You know, or maybe we come up with a plan, you know, to forestall something from happening. So I'm going to do something now that'll stop something from happening later, or correct the response. So you get the idea. If we were in class, this is where we'd be throwing out examples and talking about it. But basically, the plan needs to be, hey, what are we going to do when this trigger happens, and how do we deal with it? So in a relapse prevention plan, there needs to be a plan for each particular identified trigger. So it's not like one plan. If you have 10 triggers, then there needs to be 10 plans for how you're going to address each of those triggers. So when you address an individualized plan, then the plans are going to be essentially the same process as developing goals for a treatment plan. So you're going to use motivational interviewing and solution-focused counseling to try and identify what the client thinks would be the best plan to deal with particular triggers. The ones that they're most motivated to do, that's generally going to lead to the best outcomes. Okay, and then a lot of people forget about talking about warning signs. So a warning sign is basically a behavior or an emotion that the client or other people may see that could indicate that the person's moving towards a relapse. So a warning sign for a substance use relapse, for example, might be that the person stops going to sober support meetings. So they haven't started using again, but that's a like ding, 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 ding. Hey, warning, what's happening here? Like, why are you stopping going to meetings? That could lead you towards a substance use relapse. Or a warning sign for a mental health relapse is that a person stops showering every day. So maybe they aren't in a full-blown mental health relapse, but that again should be a ding, 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 ding. What's happening? In the past, when you stopped showering, that usually meant you were moving towards depression, because that's what's happening here. So a warning sign is something that the client may recognize, oh my gosh, I'm doing this. But in many cases, it's other people that are going to see those warning signs. And so developing a relapse prevention plan, you want to try to identify what are the specific warning signs that happen to you that suggest you're moving towards a relapse. And again, this is where assessing past relapses can be super helpful. Key stakeholders, I'm going to use that phrase again in this presentation. So key stakeholders are basically important people to the individual. So family members, friends, their counselor, their sponsor, etc. And then once you develop warning signs, you want to have an agreement or a plan for how the client or others are expected to respond when they identify those warning signs. So we're going to talk a little more in this presentation later, but basically warning signs that other people might see, you need to talk when you're doing the relapse prevention plan about, well, what should those people do when they see those signs? So if my wife sees that I stop showering every day, then what should she do? Should she call me out in that case? Should she call my psychiatrist? So the relapse prevention plan establishes an agreement about what to do when others see warning signs. Okay, so I'm going to talk about substance use and mental health distinctly here, because we're going to address both. So substance use relapses, person starts using substances again after engaging in treatment or committing to not using substances. So numerous large studies at this point have established that almost everybody relapses, especially when they first start trying to get sober or use a pledge of abstinence, both in and out of treatment rates with highs as high as 85 to 90%. But the highest rates of substance use relapse are for people who have co-occurring disorders. Almost everybody who has a co-occurring disorder will relapse at least once, to where they return to using substances in a problematic way. So there's a bunch of reasons for this. So a lot of times clients with co-occurring disorders use substances to relieve emotional or mental health related symptoms. It's their go-to. So if they start experiencing mental health related symptoms, it's easy to go back to using substances. Also, many mental health symptoms are associated with impaired judgment, which is going to interfere with relapse prevention planning. So while the person's in a good state of mind, they come up with a good relapse prevention plan not to use substances, but when they're in the midst of a depression or the midst of a full-blown panic attack, that's going to interfere with their ability to remember what my plan was and could lead back to using. In addition, some clients with co-occurring disorders discount the significance of substance use, prioritizing their attempts to manage their mental health symptoms, leading to chronic relapse. This is particularly true for people that have severe and persistent mental illness, schizophrenia, and some of the psychotic disorders, PTSD in some cases. So a lot of cases there, the substance use seems like a lesser of two evils, and the person may discount the substance use to try and take care of their mental health. So because of the even greater risk of substance use relapse for people with co-occurring disorders, the relevant and highly codependent mental health factors must be accounted for when considering triggers and events that can influence the person to go back and use again. Meaning that specific mental health symptoms may be triggers themselves that could lead to substance use. So you want to make sure that when you're developing the substance use part of the integrated relapse prevention plan, you actually look at mental health as a factor leading to substance use, not just by itself. So addressing substance use in the relapse prevention plan, the integrated relapse prevention plan, you're going to use the same format of identifying triggers, warning signs, and a plan. So that's the same for developing a substance use relapse prevention plan or any others. But there's a couple of key components you want to make sure you consider when you're assessing for triggers and warning signs specifically for substance use. So one is identifying particular people, places, and things that are associated with previous substance use. Substance use is a highly social condition. It becomes habitual, and previous people that you used with, previous places that you went, previous things you used to do when you were using have to be assessed, because those are usually major triggers for return. And then the other thing that has to be addressed is strategies to tolerate cravings. Cravings are a fact of life. As you all know, that is one of the 11 criteria for diagnosing a substance use disorder, after they established neurobiological evidence that craving is a real thing that happens in the brain. So you've got to address these two things when you're doing a substance use treatment plan. Substance use relapse prevention plan. So typical questions to identify people, places, and things. Who are the people that remind me of substance use or encourage me to use with them? Where are the places that I previously did drugs? What were the particular situations or events? Like going to a baseball game, where I used to use substances. What paraphernalia did I use with substances? For somebody whose substance use disorder is cannabis, or marijuana, and they rolled joints. Well, if they're hand rolling cigarettes, the paraphernalia of hand rolling cigarettes, can be a real trigger to start rolling joints again. And then managing cravings, who can I talk to when I feel like when I'm having a craving? Where can I go when I'm having a craving? What will calm me down when I'm having a craving? Activities, environmental changes when I'm having cravings, etc. Okay, and also part of the plan for substance use relapse prevention typically includes developing and strengthening social support systems with others who abstain because of the incredible social pressures to use alcohol and drugs. Again, alcohol and drug use are incredibly social conditions. So substance use relapse prevention plans almost always require the development of a support system or sober support system, basically an alternative group of people who are sober safe and will keep you from going back. Common relapse triggers and risk factors for substance use. You all should know these. So with the integrated relapse prevention plan, while it needs to be customized, a lot of times people have difficulty identifying triggers that could lead them back to substance use, especially when they're in early recovery. It's not uncommon for a first-timer in treatment to ask them, well, why do you think you use substances? And for them to say, well, I don't know. So in this case, you can use some common risk factors to prompt thoughts about, is this an actual risk factor for you as well? So this is not an all-inclusive list, but things that definitely are usually major risk factors: being in the presence of drugs and alcohol, experiencing cravings, being around people, places, things, negative emotions, negative, anger, sadness, loneliness, fear, dealing with pain, having trauma experiences or memories, reliving or listening to war stories. War stories are glorified memories about the good times when somebody used drugs or alcohol. Social isolation, lack of support system, relationship problems, prescription medications with intoxicating effects, suddenly having a lot of unexpected money. I had a family member that happened to. They got a very small inheritance, and that immediately ended in their couple years sobriety. Boredom and becoming complacent in your sobriety. So any of those things could be common relapse risk factors. Again, you need to talk to your client and figure out what are the particular ones for them. But these are good things in your assessment with the client to try and determine if they're also factors for them also. Additionally, events. Events are something that I found that drug and alcohol counselors often don't think about as triggers. So events are particular types of triggers, and they're really important to anticipate. So research has shown that negative life events could lead back to substance use in order to cope. So getting fired from your job, right, would be a negative life event. And so that could lead back to substance use. So it's a type of trigger. But positive life events or emotions that make the person want to celebrate also can be a trigger. Getting a promotion at work, and people are like, hey, let's take you out, let's celebrate. So you need to consider events when you are thinking about triggers. And events are usually one-time things or things that happen in a period of time. But there are common ones, right? Getting a job or losing a job, moving, packing up houses, totally a pain in the ass, definitely could be a trigger. Managing romantic relationships, getting in a new relationship, breaking up in a relationship. How are you going to handle holiday celebrations? What's going to happen when you go back to the family home for Thanksgiving and everybody's drinking bottles of wine? Going to weddings. Weddings are typically associated with people being loaded. So when you're doing an assessment of triggers for an individual, you want to look at particular events that could represent a high risk for relapse. It's also common for people to stop attending their meetings, ending their sponsor relationship, quit going to the psychiatrist, etc. So you can also see these as events that could lead to relapse. So bottom line is, in any assessment of triggers for relapse prevention, you want to think about the potential events, especially events that are coming up in the next 12 to 18 months that could represent risk, and you want to develop a specific plan for that event. All right, let's touch upon the mental health piece now. So mental health, relapse, and co-occurring disorders. So a mental health relapse is when distressing mental health symptoms come back or the regular symptoms get worse. So examples of a mental health relapse could include thoughts of suicidal ideation or making a suicide attempt, having a return of heightened anxiety or depression, increased social isolation, an increase in paranoia or delusions, developing disorganized thought or speech, dissociating or going through some kind of freeze response. Again, these are not all inclusive. There's many examples of this, but the idea is that none of these things were happening while you were in treatment or immediately after treatment, and suddenly these things start to come back, which suggests mental health relapse. So like substance use relapse, research shows that mental health conditions also experience a specific series of changes in thoughts, feelings, and behaviors before a mental health relapse. So like substance use relapse, then mental health relapse is a transitional process subject to triggers or cues in the environment that you can address with a relapse prevention plan. In other words, in the same way that relapse happens long before you pick up when you're talking about substance use disorders, relapse happens long before you make a suicide attempt. Relapse happens long before you develop a panic attack in the case of a mental health relapse. So again, like substance use, people with co-occurring disorders have much higher mental health relapse rates than those with mental health conditions alone. Research has shown that people with major depressive disorder or post-traumatic stress disorder tend to have the highest rates of mental health relapse. And significantly, a relapse of problematic mental health symptoms post-treatment often subsequently leads to a substance use relapse, meaning that you have a mental health relapse, and the fact you're having a mental health relapse then leads to a substance use relapse. However, on the other hand, it's substance use that is the most important factor in the high rates of mental health relapse. So you start using substances again, and that leads to mental health relapse. So in other words, mental health relapse often leads to substance use relapse, and substance use relapse often leads to mental health relapse. So it goes both directions. And again, this is the reason why an integrated relapse prevention plan is so incredibly important. So when you're addressing the mental health component of the integrated relapse prevention plan, you're going to use the same format of triggers, plans, warning signs, same way we talked about with substance use. But again, like substance use, there's certain key components that are considered standard that you assess for when you're developing a mental health relapse prevention plan. So one major challenge in managing mental health relapse is that mental health symptoms may affect the person's perceptions and thought process, making it difficult to reliably assess one's own risk for mental health relapse once it's started. So unlike substance use disorder, if you have stopped using substances and you don't have a mental health condition, generally your thinking process gets much, much clearer. Especially if you move through post-acute withdrawal, you're thinking pretty clearly. And so many times you may be aware that you're moving towards substance use relapse. It's like, oh shit, I'm starting to have thoughts. Oh man, I can taste that beer. Oh man, like I know that person's not good for me. Whereas with mental health conditions, oftentimes the mental health condition itself or the symptoms itself make it hard for you to see clearly or think clearly about things. So if you are depressed, you know, the mind's moving really sluggish, it can be really hard to assess your own level of depression. You know, if you are starting to develop anxiety symptoms, it can be really challenging to recognize that you're moving back into a heightened anxiety state. Or if you've got a psychotic disorder, you know, and suddenly your thoughts are starting to get disorganized, it can be really challenging to recognize, oh man, I'm starting to move towards a mental health relapse. So in some ways that's unique to the mental health piece of the integrated relapse prevention plan. So because of that, it is super, super important to enlist a support team with mental health relapse prevention plan. So what you want are supportive people who recognize the mental health symptoms and know about your specific disorder. So these are people who know me and can help me. These are the people that know what I would like to do if I start to relapse, or the people that should be contacted, right, in case of an emergency. That support team almost always includes some plan to set up a meeting with your doctor, psychiatrist, mental health clinician, or alcohol and drug counselor, when mental health warning signs first appear. Similar, I guess, to, call your sponsor when substance use relapse first appears. Same thing on the mental health side is you need to call your doctor, your psychiatrist, your clinician when mental health warning signs appear. So medication management is also a standard part of mental health relapse. So with a doctor, finding a medication that works to manage symptoms, following the doctor's recommendations even when you're feeling well. That's a very typical thing that happens. People are taking meds and now they don't have mental health symptoms anymore. It's like, oh, well, now I don't have symptoms. I don't have to take my meds anymore. Bad idea. So when you do that, that often leads to compounded effects of those symptoms coming back. Do not stop medications without consulting with the doctor. That's a huge factor with mental health relapse. And you want to carefully assess any medication changes. So many times when a doctor changes medications, there's an unknown factor how the person is going to react to that. In many cases with these drug studies, what they find is that it helps 85% of the people. 15% of the people have an increase in symptoms, but 85% have a decrease in symptoms. So the FDA then approves the drug. So it's basically, well, it helps most people. The problem is those 15% that start taking that medication may go the opposite direction. Things get much, much worse. And so when somebody changes their meds, that's a trigger or potential warning that mental health relapse could be a factor. So you need to assess for that. Developing coping skills. So with mental health conditions, it's essentially enduring through those conditions. So developing coping skills is a huge part of that. Nutritional eating, exercise, regular sleep, lots and lots of research evidence that eating right, exercising, and sleeping right are huge factors to forestalling mental health relapse. And then developing a crisis prevention plan. So the problem with a full-blown mental health relapse, especially if the person has severe and persistent mental illness, is that when they move into a relapse, they may not be able to handle their own affairs. So they may not be able to pay their bills any longer, or purchase food, or maintain hygiene, or go to their job, etc. And so a lot of times when somebody moves into a mental health relapse, they may end up homeless, or in another very difficult situation because they can't handle their own affairs. So this needs to be assessed as a risk factor and then included in the integrated relapse prevention plan, some kind of a crisis prevention plan, that if I move into a mental health relapse, what happens? So this is usually where you want to have identified people that agree to do certain things. Those people should be on the integrated relapse prevention plan by name with contact information. If I'm having a mental health relapse, these are the people who have agreed to help. Here's the people who have agreed what they're going to do. And also what types of medications the person's on. So many times, if you see people who are out in the street and they're clearly in the midst of a severe mental health relapse, they're off their meds. Well, if the HOT team, the homeless outreach team, if the PERT team goes out there and they take the person in for their own safety, if they don't have any idea what kind of medications they're on, then it takes much longer in order to get them back into a more stable state. So part of the integrated relapse prevention plan, if they've done an integrated relapse prevention plan and they're able to say to someone, call my mom, she knows what's going on, and they give that number, well, then if the PERT team calls mom, mom says, yeah, he's taking lithium, he has bipolar disorder, but he always stops taking the lithium, please don't give him, Depakote or whatever, some kind of an antipsychotic medication, he has severe side effects. So that should be included in the plan as well. And then like like substance use disorders, there's some common triggers and risk factors that should be assessed to see if these are relevant to this particular client. Again, this is not all inclusive. So using drugs or alcohol, obviously very, very common. Stopping taking medications, changing medications, experiencing acute life stress, navigating major life changes. Sometimes I've treated people who are in treatment and they make a decision while they're in treatment that they're going to leave the person who's abusive to them. So essentially, as soon as they get out of treatment, they're planning on going through a divorce. Well, that would certainly be a major life change. And so if we've got somebody who's got PTSD and they've got a heroin use disorder, and they are going to be going through a divorce when they leave, well, that would be then a major life change that would need to be accounted for in the integrated relapse prevention plan. Going through traumatic, stressful, unpleasant events, anticipating stressful situations or future tripping, having health problems, relationship conflict, loss, and grief. These are all typical things that will lead to mental health relapse. And again, as mentioned previously, the nature of a mental health relapse is that it may affect the person's perceptions, and so they may not be aware of changes that could indicate moving back towards mental health. And so you want to make sure you're assessing for warning signs. And some of the key warning signs that often happen are significant changes in routines, feeling nervous, tense, anxious, a decrease or increased need for sleep, eating less or more, going through social withdrawal, feeling bored. These are all things to potentially look for. Feeling irritable, angry, having a short fuse, having trouble concentrating, decreased hygiene, increased spending, thinking people are against you, and hearing voices or seeing things others don't. Again, this is not an all-inclusive list, but these are pretty typical warning signs with mental health. Okay, and then finally, enlisting the relapse prevention support team. So when you're doing an integrated relapse prevention plan, you want to include all the resources needed to respond to the threat of a lapse or relapse. And so, as we've discussed, key stakeholders can and should help in the construction of the relapse prevention plan, as they might have insight into triggers and warning signs that the client may not be aware of. But the final step is that the integrated relapse prevention plan should be shared with those key stakeholders so that everybody knows both what to look for and how to respond to prevent relapse. And then those key stakeholders can also identify how they will support the relapse prevention plan. This is basically the same exact thing as family relapse prevention planning, which you've all gotten in the AODS 153 class. You know, with family relapse prevention planning, you bring the family in, you review the substance use relapse prevention plan, you ask the family how they're going to support that. With an integrated relapse prevention plan, same thing. You bring in key stakeholders, family members, friends, sponsors, the mental health clinician, whoever, and you go through the plan together, you review the plan, you add anything that needs to be added, and then the person identifies how they will support it. All right, so that is integrated relapse prevention planning.